Good. You can fix it. All right, so moving on to on the table stuff. So do you guys still have your little cheat sheets? Yes. Either way, if you don't, it's in the drive. So feel free to go back and look at some of the norms on there. So lower body testing is where we're gonna start. So first things first, and as you guys know, now that you're sitting in on some evals, everybody does their eval a tiny bit different, but most of the time, they're gonna do it in the same order. Like Eric's order will always be the same. He is a creature of habit, so he's always gonna do some of those same things. So let's go over this order, and let's talk about some of these tests. So Thomas tests, let's go over what that is. So remember how they're gonna sit on the edge of the table. They're gonna grab both knees, they're gonna rock all the way back, and they're gonna let one leg fall. You guys remember this thing here? So what that's testing, so we're assessing hip flexor length, identifies any muscle restrictions, and that impacts important things like posture, gait, movement, performance, all this different stuff. So if they're tight, it can lead to a couple different things. I gave you like this little cheat sheet thing at the bottom here, so you can kind of reflect back on that. But if the thighs, so a couple different compensation patterns to look for, if the thigh lifts off the table, this means tight iliopsoas. So right here. So that's saying that if this leg has a little gap from here to the table, then we possibly have tight iliopsoas. If the knee extends and can't bend, so instead of being at 90 degrees, you see that leg kind of filter out here like this, we might have a tight rector fem. Does that make sense, everybody? Kind of picking up on some of those complications. And then if the leg abducts or rotates laterally, so kind of filters out this way, we might have a tight TFL. Also, if you guys can't see from where I'm standing, you can go over the other side. So these are some of the main compensations that we're looking for in this quick little Thomas test that we're doing. So kind of like what we talked about last time, we're painting this larger picture, right? So we're just putting the pieces together and kind of being like, is this right? Does this make sense? Kind of adding all those pieces up as we go. So that's the first part. Now we have straight leg raise. So what is it? We're assessing hamstring length, pelvic control, and potential neural tension too. So as we look at some of these things, we're looking at pelvic orientation and control of the lower body, right? So it's gonna tell us some different things with our pelvis. It's gonna tell us some different things about core control. So we're screening for any of these mobility restrictions and motor control deficits. So what this tells me as we are doing it, if I see somebody with restricted straight leg raise, my first thought is going to pelvis and where is their pelvis sitting. And we're gonna kind of get into some of those things in the next couple slides. But if our pelvis is rotated this way and our femur is already stuck back, it has nowhere else to go. So we're restricted. Kind of similar, I feel like I've showed you guys before, but watch my straight leg raise. If my pelvis is rotated like this, do you see this gap here? And I go like this, that's my straight leg raise. If I control my core and I press my back to the ground and control my pelvis, you see how much further my straight leg raise is? So we're just kind of assessing for these initial, we're not trying to get them to do anything in this assessment, we're trying to see where they're at. So we're seeing where they're already at so that we can take them where we want them to go. Oh my God. Jeez. Okay, so we have active, which is individuals' own muscles, so they're doing it themselves, and then we also have passive. So we're seeing if they align, if there's a difference between the two, because they might, if they struggle with active, but then you can take them into passive, it means that they have the range of motion, but they don't have control over it. So that paints a picture for us. That tells us kind of some limitations. So something that I kind of wanted to very briefly hit on, but put this in here for you guys to look at later, because this is kind of getting into the weeds. This is kind of getting into it, but we're talking a little bit about nutation and counter nutation. So it's basically what the ilium is doing and the sacrum is doing. So they're moving separately or together. This is where our brains are going. Are they moving together? Are they moving as one? And this kind of lays this out for us. I'm not gonna go too much into it because I don't want you guys to get too domed up about these different things, but I also want to give you the resources to start understanding where we're going with it, okay? This gives like an idea of them moving together. The sacrum is moving underneath. Yep, and it creates a bigger space. And this is a bigger picture to some of our like ISA stuff, IPA stuff that I've given you resources on. And then you guys can kind of go back and look at this. Like I said, I don't want to get too deep in the weeds on some of these things because we're not there yet, but feel free to kind of go down the rabbit hole on your own, and kind of look into some of these things that influence and where our brains go when we're looking at straight leg raise. So what we're looking for, like I just said before, pelvic positioning. So neutral, anteriorly tilted, posteriorly tilted. Are there any weird rotations or hip hikes? Or is one side better than the other? Why is that? It can indicate some sort of compensation or poor control over that side, maybe some weakness. We have leg movement. So this is considered normal, right? But we have a lot of people who have like 45 degrees. So we also are testing and retesting to see if some of our breathing stuff and our corrective movements make changes. Does that make sense too? So sometimes it's just a pelvic positioning. Just like I did here on the ground, this little tuck made such a huge difference in my ability to have a proper straight leg raise. Is it smooth? Is it controlled? Shaky? Restricted? Are you noticing any weird things happening with the opposite leg? Is the opposite leg bending or rotating into external rotation? These could kind of like show you some compensation or lead to some like signs of core control and pelvic stability, because maybe they just don't have control over some of these things. And then obviously our core and trunk compensations, which are our rib flare. Are they compensating through their hip? Are they bracing? Are they not bracing? So all of this kind of paints the picture. Does anybody have any questions on this? Making sense? Okay, cool. And then this is just kind of a picture of like where we are within. And as you guys, like let's say you guys start doing these assessments on your own eventually, highly recommend, and we're gonna have time to kind of practice this together and practice on each other. We're gonna be using goniometers. So we're gonna be actually properly measuring where we are within that. So also talking a little bit about hand placement and where you'll see hand placement. We just want to make sure that there's no bend in their knee. So we support underneath their ankle and then above their knee to kind of put them into a good position. Questions on that? Okay, so hip flexion, hip scoring. So you'll see the coaches take the range of motion and take the person's leg through their range of motion. What they're trying to do is feel for end ranges. Is it a stiff end range? Does it feel weird? Does it feel weird on the inside? Is it spongy? Is it a hard end range? So these are giving us ideas of structural things within their hip. Is there any pain? Are they pinching on the inside? So it also helps with any of these like joint restrictions. So like labral issues, soft tissue limitations. And as we get into like ER and IR, if we're testing ER and IR this way and we have some restrictions, but then we flip them over onto their stomach and we do ER, IR, and it looks a little different, that may indicate that there is some soft tissue issues. So, but for this case, this gives us the picture of like what their hip is doing, right? So like if you would take me into IR right now, I would be pinching and hurting on the inside, but that's because I have structural issues. So this paints like this big picture for us. And also too, sometimes like from side to side differences are wild. Like sometimes one side is super spongy and soft and the other side is like really stiff end ranges. So it just gives us like, I wonder what's going on here. So as you go back and look through this, first off, I highly recommend you go back and look through this on your own. I put in some videos for you guys to just kind of give you a better idea of like muscles used for hip flexion, and then how to measure it, which we will go over in the future as well when we start getting into this. So as you can see here in this picture, where our hand placement goes is on the bottom of the foot, like by the calcaneus, because what that does is help us control where their leg goes. And then in addition, his hands or her hands here at the top, which is where it could be. And then goniometer, you can kind of measure like this. We typically don't pull the goni out for this one. But yeah, questions about hip flexion? Good. So this just gives you some context to some of the things that we're looking for. And I think that these photos are some really good examples of, and it lays it out really nice on what some of these are. So fader and fader. So we're looking at flexion, adduction, internal rotation. So that's what this acronym stands for. It kind of gives you what our normal is, and then it also tells us too what the test may indicate. So if they test positive for this, testing positive meaning it is painful at the top. It could indicate hip impingement, a labral issue, or possibly even to muscle tightness. And then looking into this one over here, favor. Hip extension, abduction, external rotation. And then this also, if you test positive for this could be a SI joint dysfunction. So kind of what we talked about with like counter nutation and nutation. If some of that is dysfunctional, this may also pop up. So hip restriction, soft tissue tightness, same as the other. So I think that this paints a really good picture of like when you see us do some of these tests, because you'll see some of us do some of these fader and favor tests. This is what they're testing for. Okay, so measuring ER and IR. So same thing like before, hand placement. We're going hand on the bottom of the foot and then other hand by the knee. What we want to do is limit the amount of knee gapping. Do we all know what that means? Someone give me, what does that mean, knee gapping? Anybody? I know this is me talking, but like, give me something. Does anybody know? Right. So as you hold, if we're moving this and we're not actually moving at their femur here, we might get a different read because they may have some gapping within their joint. So let's say you have a hypermobile individual and they have a lot of range of motion and their joints are kind of loose. You may get some extra little movement and extra range of motion because you don't have your hands in the right place. You want to make sure that your ER and IR is coming directly from the hip, directly from the femur. So we just want to make sure some of those things are accurate. It's the same with the elbow. If we don't have our hand placement in the right place, you'll get some weird gapping in the elbow potentially and then get misreads. So just something to be, as you're going into your evals, because now people are coming back, so evals are starting to pick up. So you guys are about to get to see a ton of evals. I want you guys to start paying attention to hand placement. I want you to start thinking about why some of these things are the way that they are. And then hopefully you guys can pick our brains about like, okay, in that eval, what did you see? All these sorts of things. So now you can start thinking about that as you go into these evals. So, okay, ER, IR, range of motion. Measuring both internal and external. So we're looking for limited motion, excessive motion, and any compensations, which we know. Basically, the main thing with these two is we're comparing from side to side because this is giving us a picture of what's going on here and what's going on with our pelvis. So we're looking for these end feels. We're looking for anything that's abnormal or feels painful. And some of these red flags and compensations are pain, clicking, pinching, and then excessive pelvic movement. So we're looking, as we go to do ER and IR, we're looking for any weird movement happening up here in the core and also in the other leg. Why do you think we're looking for those?
Fake range of motion.
Exactly. So if we're moving through because you'll see even too, like sometimes people will go into flexion and then this will crunch, which will kind of give you like a tell of like that's their end range. Same thing with their other leg. As we go, if they go into ER, that is how they're getting extra range of motion by cheating it. So, oh no. this. Hello. So, same thing like I said before, hand positioning, make sure there's no gapping. We're gonna go over that a little bit more once we start to practice on each other, so you guys can get like a hands-on feel of what certain things should feel like. Hip abduction. So, we're assessing this because, and I know that it says it up there, but why are we assessing hip abduction? What are some important things that we do for hip abduction? Speak to me.
Loading and putting, striving.
Everything. Everything, right? So it's important to kind of see where they're at and see where their limitations are. So then that way we can kind of figure out where they are, where we need to go. So it helps identify some of this tightness, glute weakness, any asymmetries from side to side. If we have a huge asymmetry from side to side, that is a red flag to us that we kind of want to assess. May indicate some of these structural issues due to the capsule or the joint. Does everybody know the capsule? Like the actual, okay, yes. Okay. So pinch on the inside and then stretch on the outside. So these kind of break down from side to side. You see a lot of people with stretch on the, stretch, I think I accidentally put outside instead of inside. But this reflects normal most of the time. It's more of a concern when we get a pinch on the outside or the inside, pinch in general. So, and here are 2 videos. I really like these videos. So take a look at them. It kind of shows you the different muscles that are kind of being assessed as we do this test. Questions on that? Okay. Upper body testing. I am flying. Let's go. Okay. What's being assessed? So some of these are our most important tests. So shoulder flexion, glenohumeral joint mobility. I know that these words are extra, okay? Scapulothoracic. But when you look at them and you're like, what is that? Just break down half of the word, right? So scap and thoracic, so T-spine. So how they move together, how they are moving in upper rotation. Are they posteriorly tilting? Are we getting thoracic extension and rib cage mobility, or are we stuck? Overall coordination of the upper half, like is everything moving together? Is there some weird stuff going on? Neuromuscular control, and tissue and joint stuff. So let's come back to this slide. But basically this is how we measure it. We put our hand underneath the scap and then we take them into flexion. Why do you think that we're pinning their scap down? Anyone? Hello? Why do you think we pin their scap down instead of just letting them kind of like free rein? Correct. So that's like another way that we can kind of compensate through this. So we pin it down so we can get an accurate read. Plus that standardizes all of our shoulder flexions. And you'll see we don't really use the goni for this, but as you start and as you're starting out, using the goni is huge because it helps you. It's basically like an eye test. So the more you do it, the better you get at it. So using the goni to start is going to give you a good idea of some of these numbers. And then I also want to talk about really quick too, true shoulder flexion. How many of you have seen Andrew do true shoulder flexion? This one. So what we're doing there is we're actually seeing where they're losing. So if a person is here, right? So we'll set them up like this, nice and relaxed. Now imagine I'm on my back. And then as we go through, if their arm does not even touch their side, it's a 0 technically. So that's saying, like for me, I have 0. So that means every time that I go up overhead, I'm gonna compensate through something. So if I go up and I only get to 45 before I kick out this way or do something weird with my hand, that means I only have 45 degrees. So that means I'm a candidate for a high to low press because that's within my range of motion, or a low cable row. Does that make sense to everybody? So as we start giving them back more range of motion, then we can start doing some of these things because they now have the range of motion to do it. So as we go, most people don't have a ton, but if you see him do it and they kick out right away, you'll start to see the kick out here. Then you'll see the program reflects that. And that's where we're getting to, of like looking at the eval and then being able to program based on the eval and the range of motion given. Does anybody have any questions about true shoulder flexion? Okay, so compensations to look for as we are looking at this in the eval room. So we're looking for a rib flare or any like weird lumbar extension. We're looking for scapular anterior tilt or elevation. I like this photo just because I think it gives you a good idea of the posterior tilt that we talk about all the time. It gives you this idea of like, this is more retraction this way, and then this is the posterior tilt. So I put that on there for that. But is there any neck tension or head movement? So are they clenching their jaw? Just little things to note to kind of paint this full picture. Is their arm path going straight up, or do they get to a certain point and then they kick out because they can't? It's the same thing that we talked about before. Like, I think we talked about it in the last eval, but like if my arms go up overhead and my arms are bent, you know, what does that mean? We talked about it. Anyone? Hello? What does this mean if my arms are bent as I go up overhead? You don't have access to it. My lats probably are tight. I can't get up overhead without compensating. Does that make sense to everybody? Okay. Any questions on that? Any questions? Okay. Shoulder ER and IR. So we should have, and one main thing that I want to note about this one is that our total range of motion should be the same relatively from side to side. So our throwing arm probably is going to have a lot more ER than IR. And then our non-throwing arm is probably going to have a lot more IR than ER. Is everyone with me on it? I can't tell if we're locked in or if we are out somewhere else. Okay. All right. So should be relatively symmetrical. So as you do this, we want to make sure that we have similar range of motion because, and this is they do some research on it. But basically what this is telling us is that we're even. If there's a huge difference from side to side, that's a concern because that means that something balance is like way off. So we need to kind of like be like, that should be a red flag to us in the eval room, be like, I wonder why there is a huge difference from side to side. But that's mainly the most important thing that I want to hit on with this ER and IR. So hand positioning. So as we do this, first and foremost, you'll see all of us coaches kind of make sure that they're nice and loose because a lot of the time, and some of these guys, maybe not some of the older guys, but some of the younger guys, this is their first time on a table. And so they're typically pretty like tense just because they don't know what's about to happen. So you just want to make sure that you take them through it the first time, make sure they're pretty loose, make sure that they know that like this is what we're doing, and then a second time you take them in. So this is similar to arm care, similar hand positioning to arm care. However, when you do this, you're not cranking them into anything because we want to see where they're at. We don't want to crank them into any end ranges. So we're going to guide them back. We're going to notice if anything crazy. We're going to notice if they're elevating, if their humerus is kind of gliding forward. But we're taking note of any of that. Any questions about that? Questions? No questions. Okay. All right, as we get into some of this more complex stuff. So, ISA, I know Andrew briefly went over with you guys in his presentation. Give me some things that we already know about ISA, that we've already like comprehended, that we kind of understand already, so that I know where you're at. Where are we?
You got wide and narrow.
Love? Yes, we do. What else?
Got a bunch in between.
Fair. What else do we know? Anything else?
People that are wide, like the back squatting stuff's probably going to be tough on them
Right. Why is that? That's good. Why?
because how their angle is set up, their back is kind of compressed. So putting a heavy barbell on their back is just going to compress their vertebrae even more.
Right. Their rib cage already doesn't move very well, so compressing them further into this position is only going to limit their range of motion even more, which is, yes, exactly. Anything else?
Wides are generally going to be more like IR bias when they're ER bias and so on.
Yep, and this will do, I'm going to get into like a whole chart to break it down for you guys too. Snaps. But yeah, basically giving you an overview too of ISA, and it can be difficult to understand, but it gives us this underlying respiratory strategy on how they're breathing, and also movement bias, and where they hold some of their tension. So similar to kind of, I think I've told this to you guys before, but breathing in some of these things are like a tube of toothpaste, right? So if I squeeze my tube of toothpaste and I squeeze my tube of toothpaste this way, all my airflow is going that way. If I squeeze it the other way, all my airflow is going this way. So it's a balancing act of giving them what they need within our breathing correctives. So narrow. So our lower ribs are pulled inward and downward. Posteriorly compressed thorax, whatever, let's move on so that we understand some of these things. So our diaphragm is super shortened. It's associated with posterior pelvic tilt, which could be a sway back, which means that they're swayed back underneath like this way. I can't do it that well, but you'll see some of the guys, well, I'll point it out if I see somebody who's a super extra sway back. And then reduced movement variability, so increase accessory breathing muscle activity. So what does that all mean? This is kind of what a narrow looks like. It's like a little box of oats. So this is where you guys are gonna kind of refer back to, because I think this gives you a really laid out, kind of clear chart of what a narrow is. So narrow, producing ER. So associated with yielding, loading, and eccentric control. And so they're typically more capable of adapting to new positions and controlling those range of motions, because they're normally more rotational, because their rib cage actually moves up and moves back down. So they favor some of these like agility, springy type movements, because they can get in and out. Rib cage tends to be more domed, and they have a better capacity for air intake and expansion, because their rib cage is able to kind of expand and come back down. So their bias, I'm making a gait like Word doc for you guys, so hopefully we'll understand gait a little bit better too once I add that in there. But they're biased towards early and late gait phases, where ER and shock absorption are crucial. And this is like, I'm not too concerned with like muscle control, but just something for you. So when you reflect back on some of these things, and if you don't understand anything on here, either ask me now or take the time to kind of break these down in your free time so that you have a better understanding. Because these can be, it takes a long time to kind of understand some of these like complex things. Ooh. How much just got decapitated? Okay. Thanks, Sam. Okay. Wides. So more like a cereal box, not as rotational. Lower ribs are normally flared out, and diaphragm is flattened. They have a harder time descending their diaphragm. So this is normally associated with anterior pelvic tilt and exhalation-based limitations. So, and then if you have gone and looked in the drive and looked under ISA stuff, you'll see the not the worksheet, but the Word doc on PEC patterns, and then also left AIC patterning to give you a better idea. So better at producing IR, pushing, compressing, propelling. So that's why they thrive on some of these like heavier, bigger movements, but it also makes them super compressed. So they also have more thoracic and pelvic compression, kind of like what we talked about before. So it gives them more of like you'll see a lot of wides run like side to side. We'll have to find a good example of this, but it's because they're trying to find this rotation as they are running. But they have typically a more stable base for power output, so just because they're super compressed. They use this muscular tension and intra-abdominal pressure to kind of stabilize, but like I said before, it makes them so they're not as rotational, so they have to find the movement through somewhere. So within that, you'll see some of the throwers and some of these wide throwers, they're gonna be guys that are like side benders because they can't actually rotate this way. Thank you. Does that make sense? Does any of the pitching guys have anything to add to like this narrow and wide situation that we're kind of talking about that you've seen so far? Because you guys would definitely know a lot better than I of like different throwing compensations based on wides and narrows. Or anything to add?
The IR with the is like a big thing. Like I think just as a general rule, like guys that we have with IR and EVL are just different throws. Like I think just like how everything goes, like the chart, like IR is gonna be a lot more fast paced delivery. It's trying to generate some throw that's a lot stiffer. Generally we're gonna try and achieve a lot more force output in the throw, whereas like for ERs we're mainly trying to hold that.
Right. So that's how it all kind of flows together, and also why we're using it for program adaptation, but they're also using it for adjusting throwing and knowing what they're capable of and what they have. So I think a lot of times what people try to do is make everything cookie cutter. So then that way when they're coaching somebody, it's like, okay, well, you need to do this, this, and this, but they might not even have the range of motion to do that. So I think that that's where our eval comes into play. And that's what makes it kind of this super important systematic system that we have, so that we all work together to kind of get to the same place. Okay, questions on this before moving on? I know that that's a super brief overview, but we'll have time to kind of process and then ask the questions that you need. So, okay, cool. So, prone knee flexion. Oh my gosh. Let's see if that works. I don't know. It's okay. We're almost done here, so it'll be all right. All right. So, prone knee flexion. So, what are some things that you guys have seen that you think that prone knee flexion like relates to? Like, what do you think?
Tibial IR.
Yeah, exactly. Tibial IR. What else? Does everyone understand why that's true? Yes or no? Give me some sort of. Okay, so as we're going through this, our knee and our, well, we'll just say knee, but our tibia and our knee, they all track. So if they don't track properly and we don't have enough tibial IR, that will restrict our flexion. So that's why you see a lot of times as we get tibial IR lobes, is because when we have them in this prone and they're going like this, we either have a muscular restriction, which is our probably rectum, or we have a limitation within the the ability to actually properly move the femur and the tibia. So if we fix some of these movement patternings and how they track correctly, that could help us with prone knee flexion. So we are assessing quad muscle length in this position, but it also gives us this idea of most of the time when you see people having some of these like pails and rails for tibial IR, or you'll see them have half kneeling tibial IR mobs, it's because they're restricted here, and that gave us the tell. That gave us the tell that there might be some restrictions within, and sometimes you can literally see where their tibia sits. So also, I know that this is a lot of words, but basically we're addressing quad hip flexor mobility, anterior pelvic tilt. So in this position, if you see when you go to give quad strength, but then they go into anterior pelvic tilt, that is probably a sign that they have some tightness, soft tissue tightness within their quad. Are they having any pain here? Are they having any weird like symptoms? Are you noticing anything that's strange? And this is kind of giving you the tibial IR kind of spiel, but is essential for proper knee tracking and gait. So for gait, squats, change direction, all these different things. So if we don't have proper tibial IR, it can kind of lead to some of this weird like knee valgus or tracking issues, and it could be a strength issue. But a lot of times when we give people kind of feel like these tibial IRs are like eyewash because they don't understand what it's doing. But I will tell you from experience, there's a lot of times where I'll go to squat and my knees really hurt, and then I'll just hit some tibial IR moves and I'll feel so much better. And it does, it seems like eyewash, but it really does help to kind of put your tibia where you need it, where it needs to be. Does that make sense? So between the femur, the tibia, and your foot, how everything kind of tracks together is important. Because if things are not moving, like for example, if their arch collapse instead of actually having proper supination, that affects the knee, that affects their hip. So we're looking at all of these things and moving up the chain to kind of see where they lack. So then that way, when we go to program, we're programming proper things for them. We're programming things that maybe we put them on plates, like 10-pound plates instead of a slant board, because the plates allow us to get some pronation. And then the slant board allows us to get some supination in our feet. Does that make sense to everybody? Kind of following me on that? Okay, cool. I think my main thing with it is just to understand that every single thing in that program has a purpose and a reason. So starting to kind of break down like, okay, in their eval, they were restricted in this, this, and this. Let me try to see in their program if that's reflected. Okay, so T-spine rotation. They will be on the table on their hands and the knees. Normally I have them rock their butt back towards their heels and then bring their elbows in. Their hand is gonna go on their low back. Try not to have their hand up too high. It could be very uncomfortable, puts the shoulder in a weird position. As they go to, well, let's talk about first what they're assessing. So we're assessing T-spine rotation. In this rocked back position, it blocks some of this lumbar motion. It blocks some motion within the hip. So we're very much isolating what we're doing. We're isolating the T-spine. So as we go, we're gonna have them do it on their own, so active, and then we are gonna do passive where we take them through their range of motion. So let's say that we have somebody on the table and they can only get to 45 degrees, but then we can take them into the full 90. What does that mean? Yes, that's true. What else does that mean? Anybody else want to try? It means that they have it, but they don't have control over it. So that's also super important because I'm sure that that's reflected in some way out on the mountain. Where like they have the capacity to get into these range of motions, but they're searching for it because they can't control it yet. And maybe they're not strong enough to control it yet. So some of those things. And that happens sometimes too with these guys that are super hypermobile of like, they just can't feel where they need to be because they have so much range of motion. Like there was a guy who ended up last off season, he was hurt because he just kept thinking like pull back, and his arm like could never get into like the right slot. And then he eventually created enough tension and worked enough on his shoulder that then he could feel, and then he could just smooth lay back rather than trying to like search, and then he ended up putting his arm into like this weird position, which then caused damage. You know what I mean? So it kind of gives us like, and we're gonna get into some of the hypermobility stuff, but some of this, it all just kind of adds on to it. So, but yeah, as you can see here, last little thing on this too, what it might indicate, you know? So positional bias, loss of range of motion, lack of expansion, and poor, basically segmental control of their spine. So, and you can see that too, like during kind of what we talked about last time about our toe touch. You can see how their spine moves as they go to do a toe touch. If you were to look at my spine moves as one whole thing rather than segmented, which is not good. I'm a wide, I don't rotate well anymore. I'm super compressed because I lift like an idiot. And my whole body reflects that. And you'll see that if you were to eval me. Okay, so overhead squat. You'll see the coach's cue, toes forward, arms straight up overhead. And then as they get into this, we're looking for, can they get all the way down or below parallel? Are they doing better with the counterbalance? So you'll see we'll go hands out in front and then we'll hold their wrists. And if they are able to shift all the way back, what does that mean? What do you think? So if we go up all the way overhead and I'm super restricted, but then I go and you grab my arms and I'm able to shift all the way back, what does that mean? Think about it for a second. This is restricted, but when I'm able to counterbalance and shift my weight back, what do you think? They could be. However, if I have a better squat because I weight shifted this way and I basically, by holding out my wrist like this, and I create, where am I creating expansion? In my back, right? So what I'm doing is creating upper back expansion here, and I'm shifting everything backwards. So that probably tells us that they're shifted like this. So if they're shifted like this, and their pelvis is like this, possibly, I don't know, who knows? And then we do it like this, that puts the femur in a better position, that puts my upper back in a better position, and I'm shifting them back into the squat. So that just tells us maybe they would be a good candidate for front squat. Maybe they would be a good candidate for Zercher. I don't know, it depends on the rest of the stuff. But is that starting to like track on like, all right, we see this in the eval, and then now that's how we're starting to think about programming for them. Ankle mobility could be limited. We'll see when we get to the, when we test them for their ankle stuff. But basically we're looking at these common movement observations. So knee valgus here, or collapse. Are they weak in those areas? That tells us that they might be weak in their glutes. Heel lift, or do they do anything weird here? That might indicate that their ankles are restricted. Their hips might be restricted also. Are they doing a forward trunk lean? Does their head come forward? That's a compensation. So programming some of these things as we start talking about it, if they're limited in their hip, and the table will show us as well, maybe they need to be put in a better position so we elevate their heels a little bit so that way they can shift that. What is their feet doing? So, and kind of what I talked about before on like what I do in my process is I always look from ground up. So I'm looking feet all the way, feet, ankles, knees, hips, and then all the way up. So then that way I know that I've covered everything and I didn't miss anything, and I'm not just like scattered all around. Questions on that? Okay, so overhead walking lunge. So some of the common things on this, and this all happens so quickly that sometimes some of these things are very hard to kind of pick up on. But basically what we're looking here is I like to break them down into like different sections. So feet should remain straight. You'll see a lot of like weird foot positioning or their arches collapse or things like that. So we're monitoring for any weird weight shifts. Are they shifting from side to side? Are they super forward? Are they more propulsive? Knees and the hips. So knees should track in line with the toes. We're looking for anything, any weaknesses, like does the knee cave in? Core control. So are they even able to hold this position? Or are they all over the place? What else? Same thing like everything else. Is the rib cage stacked over top as they go? Are they super flared? Is there some lumbar extension here? And then last, we're looking at arms and shoulders. So arms should be locked overhead, biceps are near the ears. If they're bending, then we have some compensations, just like kind of like we talked about before. So when you do this too, like when you're looking in the eval process, I know that there's a lot going on, but you're doing a zoomed in and a zoomed out approach. So you're zooming into some of these different like foot placement, knee, hips, but then you're also zooming out and looking at the whole movement as a whole. Feel good about that? That one's like, these are pretty self-explanatory. Push-ups, can they do 3 to 5 good reps? What are their compensations? Are they having lumbar extension? Are they retracting? Are they posteriorly, are they protracting at the top as they go? Or are they short, doing little short reps? When they get to the bottom, are they tilted here or do they stay nice and neutral? So just get to understanding of how they move. And then ankle mobility. So assesses ankle dorsiflexion. A lot of times too, the coaches will just have, like I think EC does this a lot. He'll just have the intern go and take, once he feels comfortable with you, he'll have you take them through the ankle mobility. So just understanding how to do this test. So we're making sure that the block is lined up right on the wall. You have them, I normally have them start at 6, just as like a neutral position. We're looking for, can the knee touch the wall going straight in a straight line? Does the heel come up? As soon as the heel comes up or they do some weird compensations here, then we have to move them forward. So most of the time, when he gets comfortable, you guys will start to do that. So what else? Do they have issues with this? Or is there a pinching in the front or a stretch in the back? If they're having a pinch in the front, what that might mean is that their ankle sitting on their foot is not tracking correctly. Some of the things that we give them for that is a banded ankle dorsiflexion mode, because what that is doing is it's creating space. It's giving them space here. Can everybody see that though? It's giving them space here because this is all jammed up. We pull back and then we take them through dorsiflexion. And then that allows them to kind of move freely and pull some of that range of motion out. And we're also looking too for foot mechanics, because a lot of times if guys have, I mean, I'm sure you've heard it before, but like if guys have super stiff like toes when they're doing split squats, it can hurt them a lot. So are we programming things into their programming? Are we giving them the rock mat? Are we giving them some mobility stuff for their feet? You'll start to see a lot of like the, what's it called, home mobility, foot mobility. But just creating some movement in their feet so then they're not as stiff when they go to lift as well. What else? Okay, so last thing. Dang, I'm right on time. Let's go. So joint hypermobility, so we have the bait and score. All right, so this gives you a good kind of idea. There are a couple different things that we're looking for, and then a positive score is ranking greater than or equal to there. So are we having our at 90 degrees or more out? I can't do that. Thumb, can your thumb touch this way? Elbows, are your elbows hyperextended as they go like this? You'll see, do that. Knees hyperextended as they go to the toe touch. Is their spine, you can tell by their spine. Let's go back. So these are some examples. So as you can see, some examples. Ooh, that looks gross. That also looks gross. But these are just some ideas of kind of what we're looking at in the screening to kind of catch an idea of, is this person hypermobile? Do they need to create stiffness, or do we need to give them more range of motion? So we basically put these people in these buckets in order to help them, bring them to where, what they lack, bring them more of what they lack. Does that make sense? Okay, that was my last thing. I zoomed through that. Does anybody have any questions? That's a lot of information that I just word vomited at you. Questions on anything right now in this moment? Please ask as you start to kind of like sit with the information, as you start to sit in on more evals. Please think about some of these things as you're doing it, because it's going to help you start to understand why we're doing what we're doing for these athletes. And you guys are about to, it's about to pick up. We're about to get some pretty cool people up in here, so you're going to get to see some cool things. Questions on anything? All right. Break.
I thought in my head decided to try to make that eval there.
Say it again.
Just find my head
Yes.